Good morning. Welcome to the GI Cancer Institute Living Room Series webinar. November, as you may know, is Pancreatic and Stomach Cancer Awareness Month. Today, we will focus on these two cancers, often called the silent killers. My name is Nikki Lancaster, and I am the Philanthropy Manager at the GI Cancer Institute. Before we begin, I would like to welcome you to country and acknowledge the traditional owners of country throughout Australia and recognise their continuing connection to land, waters and culture. We pay our respects to their elders past, present and emerging. I'd also like to pay our respects to all the GI cancer clinicians and researchers who every day work towards finding better treatments and ultimately a cure for gastrointestinal cancer. GI cancers include all of the digestive cancers from the esophagus through to the anus. 28,600 Australians are diagnosed every year with a GI cancer and 39 die every day. These are overwhelming numbers, and that's why the GI Cancer Institute raises awareness and funds to support clinical trials to improve treatments and survival rates for these patients. You can learn more about the organisation at gicancer.org.au. Very quickly, as I'm sure we are all Zoom experts now, your audio will be off throughout the webinar, but please feel free to submit any questions you have throughout the presentations and our guest speakers will answer them. Just click on the Q&A button on the bottom of your screen on the Zoom page. Please note the chat option is disabled. We are very honoured today to have Daniel Goulburn OAM as moderator of today's webinar and our guest speakers, Associate Professor Nick Pavlakis and Belinda Steer. Daniel Goulburn has served in leadership roles in various community organisations in the areas of health, education and sport in a voluntary capacity for over 40 years. Following the death of his beloved wife, Rochelle, from pancreatic cancer, Daniel and his family started Purple Our World, a social media movement to raise awareness in the community about pancreatic cancer and its devastating impact on families. Daniel chairs the Australian Pancreatic Cancer Alliance and sits on World Pancreatic Cancer Coalition Steering Committee. Our guest speaker, Associate Professor Nick Pavlakis, is a medical oncologist and senior staff specialist at Royal North Shore Hospital in Sydney. Nick has 20 years of experience in the field of oncology, clinical and translational research. And since 2001, Nick has been developing research with the AGITG and GI Cancer Institute, and his latest study, Integrate 2B, is a global clinical trial aiming to improve treatments for people with stomach cancer. Belinda Steer, our second guest, is the joint head of the Nutrition and Speech Pathology Department at the Peter MacCallum Cancer Centre in Melbourne. She is an accredited practicing dietitian with over 10 years of experience in clinical nutrition, specialising in upper gastrointestinal cancers. Belinda is lead investigator on the AGITG GI Cancer Institute study called Randoms for pancreatic cancer. Thank you, Daniel, Nick and Belinda for joining us today. And now I'm really pleased to be able to hand over to Daniel Goulburn, our moderator.
Thank you, Nikki, and good morning to everyone. I'd like to thank the GI Cancer Institute for asking me to moderate this conversation this morning. As Nikki has said, pancreas cancer and cancer of the stomach are often called the silent killers, but us advocates sometimes refer to them as forgotten or even neglected cancers. I'd like to begin the conversation this morning noting that the pancreas and the stomach both play a part in the digestive system by asking Belinda to comment. Is there anything that can be done to prevent these cancers? Should we be aware of any lifestyle effects, or is there a good diet that we should be having? Belinda?
Yeah, thanks, Nick. There is definitely some things that we can do individually to help prevent these cancers in the first place. So as a general healthy wellbeing point of view, maintaining a healthy weight is always very important when it comes to preventing any cancer, but particularly pancreatic and gastric cancers. So if you're overweight, losing weight, but if you're of a healthy weight, just maintaining that weight. Also being regularly active, so physical activity is a really important part of preventing cancers, so trying to aim to get that sort of 30 minutes of physical activity at least 5 times a week is really important. But from a diet point of view, which is obviously my area of expertise, there is definitely some things that we can do to help prevent these cancers. So following a healthy diet, which is a very broad and probably a bit of a vague comment, but in particular when we're talking about gastric and pancreatic cancers, I think it's really important that people ensure they're eating a wide variety of fruits and vegetables, and also whole grains is the other really key food group, if you like, that you should be including in your diet every day in really good quantities. In terms of things that we should be avoiding, there is really quite good evidence that avoiding and limiting alcohol intake, as well as highly processed meats and to some extent red meat, is linked with gastric cancers in particular and pancreatic cancers. So making sure red meat's an important part of our diet, but making sure we keep that to just small amounts 2 or 3 times a week, and avoiding those really processed meats such as salamis and mortadellas and those types of things. The other thing that's linked quite heavily to gastric cancer is salty or salted foods and smoked foods. So trying to avoid or very much limit those types of foods in our diet can definitely help us to prevent gastric cancer. And then the other thing as a lifestyle thing is really smoking, which as we know is linked to many different cancers. So you're trying to avoid that or quit that where we are a smoker. So they're the key things, Daniel, that I would suggest people try to do if they're looking at trying to prevent cancers.
Well, thank you, Belinda. May I just talk to Nick a bit? May you'd like to comment about the signs and symptoms of these cancers, Nick, and are there any common symptoms between the two?
Yeah, sure. Thank you, Daniel. In the early development of the cancer, there may be no symptoms at all, and that's why you refer to as the silent cancers, because a small ulcer in the stomach could have 0 symptoms. An ulcer that causes bleeding could declare itself early in the stomach. But one that doesn't cause bleeding will not cause problems till it's quite late. In the pancreas, similarly, a very small tumour in the pancreas, which is a deep organ inside the abdominal cavity, may cause no symptoms unless it's close to the bile duct, where it can present sometimes early with jaundice. So the problem with both of these cancers is they can often lay low, silent for some time. By the time they declare themselves, they're more advanced. And the types of symptoms that are common to both would probably be loss of appetite, loss of weight, general malaise and fatigue, and just a feeling of being unwell. So there's a fairly non-specific symptoms, and we often find when we have a patient diagnosed, in retrospect, they say, oh yes, I've been losing weight for some time. Pancreas cancer can also be associated with pain, particularly going through to the back, emanating from the front as well. But there is no, I guess, specific pathway of symptoms that is consistent, that can vary from patient to patient. But there is, as you see there, a common thread across those two tumours.
Nick, perhaps you'd also like to comment on the difficulty of screening these two cancers, and what part does endoscopy and gastroenterologists play in that screening?
Yes, thank you. I'll start with pancreas cancer first. It's the hardest one to screen for, because you could use an endoscopy to evaluate a lump when you see it, but the issue is trying to find that lump in the first place, and it is difficult because even CT scans may find it difficult to note a very small and early cancer. So we still got a way to go in terms of early detection and investigations that may lead us to early detection for pancreas cancer. The best we have, unfortunately, is a CT scan at this stage in appropriate patients. As far as gastric cancer is concerned, if you look at Japan, Korea, the Southeast Asian belt, where the incidence of gastric cancer to them is what colorectal cancer is to us, which is the second most common cancer to us, they do use endoscopic screening, and they pick it up early, and they have better outcomes as a result. In Australia, where colon cancer is more common, we do bowel cancer screening. So endoscopy can pick up early tumours. And also it can be used to evaluate a suspected lump within the pancreas when you add an ultrasound to it. So the gastroenterologist is the lead diagnostician in both of these cancers in many cases.
Yeah, that's interesting about Japan and Korea. I'm going to throw Belinda in the deep end here. Do you have any idea whether that's diet related as well as to whether they're more common cancer being the stomach cancer?
Yeah, there is some relationship there, Daniel. So as I referred before, high salt intake is linked with gastric cancer, and in Japan that is definitely an issue. So as we know, a lot of Asian foods are very salty, so their diet is quite different to the Western diet and includes a high intake of salty foods. So that has been definitely linked to their higher prevalence of gastric cancer, and they're very much encouraged to reduce their salt intake.
That's also very interesting. Yes, Nick and Belinda, it's also very difficult to treat both these cancers. Perhaps you'd like to comment on that as an oncologist and then also as a dietitian. The multidisciplinary approach to treatment. What would you like to add to that, Nick?
Oh, well, I think you've started the ball rolling. Definitely this is a disease that requires a team approach. Both diseases, I should say. Nutrition is a key factor in the ability to offer treatments to patients, because many may have come into the point of diagnosis having lost fitness, weight, and general capacity to have the treatment. Then the treatment itself has an impact because we give chemotherapy in both circumstances, often before and after surgery in patients who are operable. And then the surgery itself diminishes capacity to maintain and alters the ability to maintain good nutrition afterwards. If you lose part or all of your stomach, or if you lose part of or all of your pancreas, which is important for digestive enzymes. So it is a tricky disease and definitely requires a team. We have dietitians are essential to both of these tumor types, both pre and post treatment and during, particularly with chemotherapy. We also recommend people maintain exercise to maintain fitness. And the types of treatments that we involve would be surgery, radiotherapy, and chemotherapy in general.
Before I throw to Belinda on that, Nick, I'm aware that the Whipple operation is extremely invasive. Is stomach cancer, the removal of stomach cancers and so on, just as invasive?
If you had to say what's the biggest operation, I'd put Whipple's up high, and then I'd probably put the stomach just below it. They're both invasive because they're really right at the top end of the gastrointestinal tract, where your food enters your gastrointestinal tract, and everything then follows in terms of absorption of nutrients and so on. So they are pivotal to our survival. But you can live without them. I mean, and you can go on and have a normal lifespan if the disease is picked up early, and we can make lifestyle modifications, adaptations to diet, etc. But each individual responds differently to that, and not everyone will follow the same pathway. There are some people who've lost their stomach, they learn to adapt, eat small, regular meals throughout and get on with things, and others who struggle. And I guess you need a good team approach to help manage those who are struggling most to get back on track when they're having difficulty.
That's a good segue to you, Belinda, in terms of difficulty after the operation. What sort of diets do these patients need throughout their treatment, even from the very early stages of chemotherapy and radiotherapy right through to post-operative?
Yeah, look, as Nick's alluded to there, often these patients present with eating issues at the get-go. So they have a lack of appetite, they might have pain with eating, they might be having bowel issues as well. So there's lots of things that need to be addressed early on. But I mean, as a general comment in terms of diet throughout treatment, pre and post, for these patients, it's really about trying to get them to eat enough to maintain their weight, because we know that patients that maintain their weight tolerate their treatment a lot better. And again, as Nick was saying, if they're maintaining their exercise and their fitness and maintaining their weight, they tolerate treatment, they can have their full dose of treatment, which is going to bring about the best outcome at the end. So I know often, and I'll say male patients predominantly when they get an appointment for a dietitian are always like, oh, I don't want to see the dietitian. You know, they're going to tell me I have to eat fruits and vegetables. And I always say to them, that's why I love my job as a dietitian working in GI cancer in particular, but in cancer generally, is that we get to tell them to eat whatever they want, whenever they want. You know, if they feel like some cream on cornflakes for breakfast, go your hardest. So it really is a very different diet to what the general public would perceive as what they need to eat when it comes to cancer. A cancer prevention diet that I talked to before is so different to the diet that you follow when you have a cancer diagnosis, and particularly when you're undergoing treatment. So we very much talk to people about small frequent meals, eating what you feel like when you feel like, throw out the door the idea of breakfast has to be cereal or toast. It might be that you want soup for breakfast, or it might be that you want porridge for dinner, and that's fine. It's really about when you feel the best, you eat the best. So make the most of those times. And yeah, the healthy diet definitely goes out the window. We're very much focused on higher calorie, higher energy foods, and high protein foods is the really important components that we focus on. So it's getting about the most nutrition that you can from each bite of food that you have, because people with gastric and pancreatic cancer eat so much less than they would usually. So we need to make it really valuable and get as much in as we can. So yeah, I think that's comes back to why I love my job. And I think, you know, being able to help them through that, work through their symptoms and give them some practical approaches that they can take with their diet that can actually help them feel better, help them tolerate their treatment better, help them get better outcomes. We really can make a difference throughout treatment. And to bring it back to a patient, I treated a patient with gastric cancer, and I think he's at least 5 years, but probably even more. Time goes so fast past his treatment now, and I often run into him at my local cafe, and he still to this day will always give me a cuddle and thank me for all the, you know, fantastic work that I did, and say that I was the one that got him through the treatment. I always tell him not to tell the surgeon that, but you know, to this day he remembers me. He knows what I told him, and often he'll still ask me the odd question because he is still having some problems even though he's so far past his treatment. So the issues with diet, you know, start at the start, and they carry through for a very long time. And as Nick was saying, even though we remove stomachs and we remove pancreases that are vital to our ability to digest and process foods, we can still live normally. It does just take a bit of modification and support along the way.
Thank you, Belinda. Thank you very much for that. It was all very, very interesting. Perhaps we should turn our attention to the research and to the trials that are currently in place. I know, Nick, you're very involved in Integrate 2B, and Belinda, you're very involved in the randoms clinical trial. Perhaps each of you can just give us a rundown of what's involved in the trial, what you're trying to achieve, and hopefully the outcome that you'll get there. Nick?
Thanks, Daniel. So Integrate was a program that we started several years ago to investigate a drug called regorafenib, which is an oral agent that targets blood vessels around tumours. It was shown to be effective in bowel cancer and another cancer called GIST. So we did a study and found a very promising result in people whose disease had progressed through chemotherapy. And we extended that study internationally in broader terms, Canada, Korea, Japan. And we nearly finished that second study, Integrate 2A. While we've been doing that study, research has shown that if you add an immune therapy agent, a checkpoint inhibitor we call them, this particular drug being a drug called nivolumab, to this particular drug, it looks like you get an even more powerful effect. And one of our collaborators from Japan actually ran a small study with that. So we've now moved on from just using the single drug, the regorafenib, to this combination with immune therapy, and partnered with our colleague from Japan, Dr. Shitara, and we're leading an international trial that will commence next year in people whose cancers have progressed from chemotherapy. These are advanced gastric cancers. Internationally, this is a big problem. And we're offering them this combination compared with chemotherapy to see if we can prove its superiority and therefore define a new standard of care. And it offers hope to people who were unlucky to have cancer relapsed or who never had operable cancer, but who were trying to maintain a survival and keep living with the disease. And one of the things we've noted also is you can give lower doses of the drug with this immune therapy and therefore get less side effect, we hope, and therefore might be able to maintain a better quality of life. So that study, the 2B study, is moving on from the study, the 2A, which is the tablet alone, and will be hopefully commencing early next year.
Excellent, excellent, Nick. Belinda, randoms, as far as I know, is one of the few studies into nutrition with these cancers. Has there been any others internationally? And just go through randoms for us if you can.
Yeah. Look, there is definitely other studies conducted in nutrition in gastric and in pancreatic cancer. The trouble, nutrition studies are quite difficult to conduct, particularly interventional studies, and partly because it's hard to control what people eat. We can give them an intervention that we'd like them to do, but controlling what else goes on in the side is very difficult, and that can have a big impact on the outcomes that we find. So generally, interventional trials don't have great compliance, and we don't get great findings from them, unfortunately. And the other challenge with nutritional trials is that we can test individual nutrients or vitamins, if you like, in a trial, but in reality, we eat whole foods. And when an individual nutrient is in the context of a whole food, it interacts very differently. So conducting a trial by taking a tablet, for example, of vitamin C, and finding that's effective, but then trying to implement that over into whole foods can find that it's not effective because of the other interactions that are happening. So it's a challenging area to work in. Our randoms trial that I'm leading with my colleague Katie Benton in Queensland is a trial that we've come up with, and it really came about when Katie and I were chatting at one of the AGITG meetings that we have about how can we better assess patients in the clinical setting to determine what's happening with their body composition. So what's happening with their muscle mass, because there's been a lot more research recently at looking at body weight is not a great indicator of what's happening inside of a patient's body. So you can have two patients that weigh the same, but one person can have a good amount of muscle, the other person can have a lot less muscle. And as you would expect, that has a big impact on function for people, so being able just to do their day-to-day activities. But also it has an effect on treatment because the way that chemotherapy, for example, is used in the body. So we were really frustrated that we can weigh someone and we can do some little subjective assessments, but we can't really tell what's happening with their muscle mass inside and work that out well. There is a research tool available where we use CT scans to determine a person's muscle mass, but that takes training to work out how to do that. Obviously, you need a CT scan, which we get quite a few with gastric and pancreatic cancers, but they are only done at certain times, and it's not really reasonable to ask a good person to go and have a CT scan just so we can assess their muscle mass. So we have to have access to CT scans. We need to be trained to be able to do it, and it takes a bit of time. It's not just a look at a scan and you can get the answer. So it's not really practical when we're sitting in a clinic room with a patient. So what randoms is it's about looking at the gold standard, being the CT assessed body composition, compared to an assessment tool that we use in the clinical setting, which is called the patient, I've just gone blank, the patient generated subjective global assessment, better known as the PGSGA. Which does involve a subjective muscle assessment. So what we're trying to see is, does our PGSGA, is it a good enough standard compared to the gold standard for us to work out that someone has lost a lot of muscle? And therefore, after that, if we find that's the case, we would then look at, okay, what are the interventions that we need to put in place to prevent that muscle loss and to be able to accurately assess it at many time points to keep a patient not only maintaining their weight, but maintaining their muscle mass, and therefore, again, hopefully achieving better outcomes and better quality of life for our patients.
Well, thank you, Belinda. I might now just talk to some Q&A type questions if we can, and we've got a couple already, but I'm actually going to take the prerogative of a moderator and direct the question to Belinda. My wife, during her 16, and a personal experience, my wife during her 16 months of chemotherapy and radiotherapy didn't have a lot of appetite. So she just didn't want to eat. And of course, weight loss was considerable during the journey. What role do supplements play in that treatment period?
Yeah, so you're referring to more the drinks that exist, Daniel, rather than...
Yeah, I've forgotten the name of them. But
there's so many.
Yeah, thank you.
Yeah, so I think a very well-known one is Sustagen, because that's promoted to the general public as a good thing to have. And as dietitians, we do use that quite a bit because it's quite well tolerated. People tend to like it. But there are so many, and there's always new ones coming out, and often new ones coming out focused at cancer patients as well, because not only do they have a lack of appetite and things, they have taste changes as well, particularly through chemotherapy. So sometimes they find sweet things extraordinarily sweet. So the newer nutritional supplements that are coming out tend to be savoury or don't have as sweet a taste, so that we can try and get our cancer patients to drink these, because they are fabulous. So they're essentially a meal in a drink. So often they're only sort of 200 mils, maybe 250 mils, so a small quantity, but they're loaded up with the protein and the calories that we spoke about that are so important during treatment, but also vitamins and minerals. So they're equivalent to sort of having a decent meal, but usually drinking is much easier than sitting down and facing a big meal. So we do use them a lot, and we are very fortunate that there's so many out there, because if someone doesn't like one, we can move on to the next brand or the next flavour. If they don't like milk, there's more cordial-based ones. And now there's even coming out things like soups and yogurts and puddings and things that we can use as well. So they are really important. And, you know, when I was saying before about making every mouthful count, that's where these types of things come into play a lot, and where their lack of appetite, if we can get them to have a drink as a replacement of a meal. Not the idea. Ideally, they supplement, so they're an addition to eating, but sometimes they are used where someone doesn't feel like eating, they can take that, hopefully helping them achieve what they need to get in terms of nutrition in each day.
Well, it's certainly good to hear that there's been improvements, because 7 years ago they weren't very tasty.
No, I won't say they're fabulous yet, Daniel, but we're getting closer every time.
Nick, endoscopy, colonoscopies. There's obviously gastroenterologists who do both. Is there a bit in the middle that misses out?
Yeah, you can't look at the whole gastrointestinal. You can obviously only look at the top right to the beginning of the duodenum and just sneak in. And then the small intestine misses out. So there is a thing called a pill cam, which can be used you swallow that and it traverses through the gut, and then you takes pictures along the way, and then you have to look at that afterwards. The question is sensitivity. A very small tumor can be difficult. But for the tumors we're talking about tonight, in terms of bowel cancers, colonoscopy is a great test, and in terms of stomach cancers, it is a great test. Small intestinal cancers, which are far less common, are definitely harder to diagnose because they cannot be reached through these other means.
I think there's another question here for you, Nick. Is there research happening in other cancers that can help treatments for stomach and pancreas cancer?
Yeah, you know, when you treat several different cancer types, one of the things is you can transfer learnings from one to another. So I actually treat gastrointestinal cancers, but I also treat lung cancers, thoracic cancers. And there's been more success in research with immune therapy, for example, in lung cancers than there has been in gastrointestinal cancers. And the research to evaluate resistance in one area can then be applied in the other. We've understood why, for example, gastric cancers, we don't know completely, but we do have some understanding as to why gastrointestinal cancers are more resistant to new therapies such as immune therapy. And there are methods applied to try to overcome that. In fact, our Integrate 2B study, which uses this drug regorafenib, that principle has been applied to kidney cancer and it's shown success. And it's also been applied to lung cancers. There are clinical trials there. So that biologic principle of overcoming resistance can be passed on across several tumor types. And if you see a discovery in one area, you can then explore whether that could be applicable to your circumstance. So I think it's important you look widely and don't narrow down your focus so much that you miss seeing something in the horizon.
Nick, perhaps you can also comment. I'll throw you in the deep end, maybe. But Master Plan is another clinical trial that's, as I understand it, has grown out of the success of a treatment in another cancer in terms of directed radiotherapy to the tumour in the pancreas. Can you make a comment on that, Nick?
Yeah, so master plan is evaluating the application of a focused radiotherapy technique called stereotactic body radiotherapy, SBRT, very targeted radiotherapy, which has the advantage of giving high concentration of radiotherapy with less scatter around, so better outcome, less toxicity. The challenge in pancreas is because of where it is actually seeing it clearly and localizing it. And what master plan's evaluating is whether, as a routine, it would be advantage adding this to our conventional chemotherapy, which we do as part of our practice, in people prior to an operation. So try to reduce your risk of recurrence of a cancer, perhaps facilitate the surgery better, and ultimately get better outcomes. So it's a landmark trial for Australia. It's involving, I guess if you think about it, the whole multidisciplinary team, the med-oncologist to get through the chemotherapy phase, the radiation oncologist to give the therapy, and then ultimately the surgeon who follows on with the surgical outcome. And the cases are discussed both at the beginning and along the way at our multidisciplinary team meetings, where we sit together with a bunch of specialists, radiologists, look at the scans and obviously track the patient's journey along the way and hope that they're progressing in the right direction.
While we're on clinical trials, perhaps another question to you, Nick. Is there a link? No, actually, I'll just deal with this other question first, if you can. How do you find patient compliance for pancreatic enzyme? I'm just trying to find it there. Replacement therapy. Is there a good acceptability or resistance to the number of tablets?
That's a good question. I might answer and see what Belinda has to say after this as well, because we do involve each other in these discussions, certainly myself and the dietitian. Look, patients generally have an aversion to taking tablets. And the thing is with pancreatic enzyme supplements is you can tell the success of your therapy by the outcome that comes out the bottom end. So basically the pancreas enzymes are involved in absorption of and digestion of fats, and predominantly fats, but also some protein. And if you're not successful, you'll have very offensive poo, very smelly, and a lot of wind. And if you're going to follow the type of diet that Belinda was talking about before, where you're not eating much, but you want to have a really high calorie meal and have high fats, you're going to need more of these enzymes to digest those components of the meal and get the nutrients. Otherwise, they're just going to run straight out of you. And so I try to tell people, well, we have to have these awkward discussions about the poo and what's happening, and say, look, what's happening at your bottom end? I say, well, you're not taking enough prion. And people are worried that if they take too much, they'll do themselves harm. And that's the opposite. If they take more, they'll digest their food better and get a better outcome from it. But it does take education. And I often find, because we have, particularly with pancreas cancer patients, often they're seeing the dietitian in parallel. If I haven't seen the patient recently, the dietitian comes up and says, Nick, they're not doing their creon. So I have to reinforce it. And we're constantly talking to each other to emphasize it.
Yeah, and yeah, I would agree, Nick. That's definitely my experience too, is it's a team approach to pancreatic enzyme replacement. So firstly, acknowledging that they need it and that it might help them, and then working through getting them using it. But I think from my experience, when it works, people realize it and they are on board, and they are so thankful that they got put on it, but also they are very compliant with it for that reason, because they can get really severe wind pain and they just continue to lose weight despite eating. So if they can make the enzymes work, if they take them appropriately, then suddenly they sort of turn that corner and that pain subsides, and they can actually start to maintain their weight and potentially gain a little bit of weight. So it's tricky to start with, and I agree, patients are adverse to taking more pills, and it's about taking them, that's really specific. You have to take them when you eat. So they might have to sit down and take 2 or 3 tablets, I say, with their first mouthful of food, or if they're eating for a long time, they take some and then take some more throughout their meal. They have to remember, so they have to sit them on the table next to where they eat so they don't forget them. So it can be really tricky to get into the routine of taking them and taking them regularly. But once they take them and we find the right dose and it works, then I would say people are hooked, if you like, and continue to take them really well.
Another question for you, Belinda, if I can. It's a question, are you accepting enrolments to randoms? And what's the criteria for acceptance?
Yeah, look, Randoms is just starting to open. So we've just put out invites to sites at the moment. So we have had a couple of sites agree to participate, and we're just sorting out the back end in terms of agreements and things with that. So look, hopefully by early next year, we will be accepting enrolments onto Randoms. In terms of participation, it's a sub-study to the master plan trial. So it's for patients that are already part of master plan. They will then have the option to sign up to the sub-study of Randoms as well. So if they are eligible for master plan and participating, then they are eligible for Randoms as well. So it's pretty easy from that point of view. Another
question for you, Belinda. I'm just going to read it out. Can you use the DEXA scans that are a lot of gyms to measure muscle mass over time? Would this be comparable to a CT scan?
Yeah, look, CT scans are what they call the gold standard, so the best, but definitely DEXA is a very close second, I would say, is a very great measure of muscle mass. And yes, you can use those over time, obviously, as well. So they're a really good option. I think, again, you know, the reason we're doing Randoms is from a clinical point of view, we don't have access to DEXA scans as frequently, often not at all, to be honest, but as frequently as what we would need it in the clinical setting. So that's why we're trying to find a tool that we can use in the clinic space on a day-to-day basis. But definitely DEXA scans are good. The bioelectrical impedance analysis, so BIA scales that are often used in gyms these days as well, there's a lot of those and they are getting better and better, are quite a good measure as well. Not as good as CT scans, but I think sometimes it's less about the number and more about whether it's moving up or down. So that's what we tend to focus, even just with weight. Patients get caught up about, oh, my scale says I'm 63 and your scale says I'm 61. And it's not about the number so much. It's more about, is that number staying the same or is it going down? If it's going down, then I'm worried. If it's staying the same or going up, that's great. So, you know, when we're looking at other ways of measuring muscle, it's the same to some extent, that they may not be super accurate, but ideally they're specific and sensitive enough that they will pick up changes. And that's the key thing that we're looking for.
There's been a couple of questions about clinical trials, which I'll combine, and perhaps both of you or Nick, you can comment on. How long does it take to develop a clinical trial? And also another question is, it's very difficult to access trials in regional areas. And how can this be addressed?
Sure, thanks for the question. So, well, you can come up with an idea very quickly. I could write a one-page concept in a night, in a day, but to develop a trial, you then have to pitch that to a group. You have to gain interest across the community to see if that question is of value to the broader community. And then you have to, once you've secured that, you have to write a protocol, you have to apply for funding. And I guess if for a small trial, we call it a phase 2 trial, our very first integrate trial probably took about a year from the commencement of the idea to the one page, to the protocol, to getting a grant. We had support, independent grant support for doing that. An international trial will take you longer. You have to set up an international steering committee or forum. You bring them together. You may find that there's a bit of variation in practice, despite what you're doing across different countries. And you have to consider that and allow for that, because they're going to be enrolling patients in the trial as well. So an international trial generally could take up to 2 years at the most, from an idea to actually commencing. And then, of course, you've allowed for ethics submissions and consumer feedback and feedback from other groups along the way. Ideally, we want to shorten that as much as possible. And I will tell you that if you have a trial in an area where there isn't much happening, you can try to fast track it in those areas. It's where the competition's greatest that it often takes a bit longer. For the country patients, there are many regional centres that are have clinical trials units attached to them. And some are participating or have participated in Integrate, certainly in regional New South Wales and Victoria. Again, whether a regional site takes on a trial depends on how common or how likely they are to see patients with the disease in that area. What's been developed in Australia through a group I was a part of called COSA was what's called telehealth model of clinical trials. And that was where you allowed a trial centre to be affiliated with another centre and then open the trial if a patient was enrolled and used the medium that we're using now to enable trial enrollment of a patient without having to physically be there in person. So one of the things we've gained from COVID is a better understanding of the application of clever ways of offering trials to people in places that they otherwise may not have had access to it. And I hope we're going to get better at that. And I do think the COVID situation, the technology we're using for this webinar, for example, is going to enable us to give a greater equity of access to patients for trials.
Belinda, there's another question actually here. Why is there such an adverse reaction to sugar after a Whipple procedure, and can it be counteracted?
So the pancreas, as well as being involved with, or as key part of digestive enzymes, secretes insulin, which is what actually helps us to manage the sugar that we eat in our diet. And so with Whipples, generally the ability of the body to then produce insulin is gone, and people then have to be externally putting insulin into their body. So they're having insulin injections or potentially tablets. So the ability to digest and absorb sugar becomes very, very challenging after a Whipples. So that is, I mean, the key reason around why, but also people often get turned off sweet foods and things following surgery, and that's the last thing they feel like eating. So that can be part of it, and it takes a little while for that to come up. But it's not just about, I mean, sugar is not just in sweet foods, it's obviously in fruits and vegetables and breads and cereals and things as well. So when it comes to the pancreas and it comes to insulin production, when we don't have that, then any form of sugar that we're putting into our body needs to be managed through external insulin.
After a Whipple, you basically become a type 1 diabetic, is that correct?
That's right, yeah.
Perhaps a question to both of you, or either of you. What role does family history, genetics play in these cancers? Is there something that should be aware of for people?
I think it's important. I'll start, if you don't mind. I'll pass on to Belinda afterwards. So, yes, both cancers can be associated with genetic predisposing factors. There is the general proportion of patients who carry a gene that gives rise to both of these cancers is quite low. It's less than 5%, to put it into perspective. In other words, most cancers are out of the blue cancers, but there are a few identifiable syndromes where you can test for the presence of the gene and therefore screen early for gastric cancer. A bit harder to screen, as I pointed out earlier, for pancreas cancer. And you can do genetic tests to look for these. The key is to actually look at your family history. The common thread across most genetic cancers is the development of cancer in a member of the family at a young age, generally, rather than late age. If you look at the common age for pancreas cancer, it is generally later, and equally for stomach cancer. So any cancers in your family that occur early are a signal. And there are some syndromes, for example, in pancreas cancer, where you have a history of breast cancer or colon cancer for hereditary genes in those that can give rise or increase the risk of getting pancreas cancer. So the first thing to do is just do a family tree, have a look at it. And if there's a clear pathway of early cancers, then it's important to explore that. But remember that it's less than 5% that will carry a gene that we can identify that will give us some predictive factor. For the rest, we say if you have a family history, that elevates your risk, but not in a way that we can measure, or we just say, look, follow the types of lifestyles that Belinda talked about. You know, minimize your environmental risk factors. Don't smoke, minimize your alcohol, have a balanced diet, exercise, and that protects you as best you can. At the end, it's the play of chance in most cases, Daniel, unfortunately, and you can't control things that much, but you can at least try.
I'm very conscious of the time, and I just want to ask one last question. And it's from a person who has registered for the webinar. Does the speed for which COVID vaccines have been developed cause any concern regarding their efficiency and safety, considering the usual time taken for trials? And if we could get very short, Nick, and then we have to move on.
Okay. Vaccines are different. You can measure the success through the identification of an antibody quickly. You won't know until you've tested it how well it is in protecting against the virus. Cancer therapies do take longer. Our outcomes take longer to measure, and it is different. So you can trust the methodology, recognizing that TGA and FGA won't approve a drug if it hasn't been through rigorous processes.
Sorry, people on the webinar, we haven't got time to answer all your questions, but they will be followed up by the GI Cancer Institute. Before we leave, I'd just like Nick and Belinda to talk a little bit, very quickly, about the Gutsy Challenges that they are both participating in 2021. Nick, you want to go first?
I'm going to Kosciuszko. We're going to do a walk across the top there on I think it's March next year, and we're raising funds to support clinical and translational research. We're trying to get as many people to join the team as possible. It's one day. We picked it because we thought no matter what happens with COVID, we should also be able to drive down and get there. So.
And Belinda, based in Melbourne,
Yep.
what's your Gutsy challenge?
A similar story, keeping COVID in mind, we're going for a Victorian-based Gutsy Challenge next year. So in September next year, I'm taking on the 12 Apostles Walk. So it's a 4-day walk. It's nothing too strenuous, I don't think, and we get to stay in a beautiful eco resort and get fed very well every day, which is so important for a dietitian. So please, I would really love some people to come and join me on this. I'll call it a walk rather than a trek, where we get to see the beautiful Victorian coastline at its best in September and eat some beautiful food together.
Well, thank you, Nick. Thank you, Belinda. And I don't know whether everybody knows, but this is clapping in Aslan language. So thank you very, very much. And I'd now like to pass back to Nikki. Thank you.
Hi. I cannot even begin to thank our speakers and our moderator, Daniel. That was really amazing. And thank you so much for your time today and all this valuable information about nutrition, clinical trials, and everything to do with trying to find better treatments for patients and people with pancreatic and stomach cancer. I would recommend that if you would like to find more information out about the Gutsy Challenge, if you'd like to join Nick and Belinda on their Gutsy Challenge next year, go to our website at gicancer.org.au or contact Melanie at gicancer.org.au. Thank you so much for your interest in the Living Room Series webinar, Unlocking the Mysteries of Pancreatic and Stomach Cancer.